And it's important that we know a few facts about the life of a surgeon. Rajkumar said that generation becomes 5 years. I don't know if it takes 5 years to become a surgeon, but in my time it took about 10 to 15 years to become a surgeon. His career used to be about 30 to 35 years. Works for about 10-15 hours a day. Most spend less than an hour on health, except Raga, who runs marathon, and few more. And they have high levels of stress and burnout. Neurosurgeons and CTVS surgeons pay the highest premium in the US, and few pay importance to the health hazard they face. So this is a talk I gave some time ago, and I think Ajay asked me to talk more on the radiation aspect of it. So if you see in the literature and journals, 19 jobs where you are most likely to kill yourself, physicians still rank second. And we know so many residents and neurosurgical residents, especially commit suicide. I don't know why, but there is a lot of stress in the youngsters as well. And as mentors, we see that the mentees are always stressed. They want more hands-on. We want them to do more research and training and things structured. So things have changed. And being an ortho spine surgeon, I looked up the literature and I found that there is a lot of musculoskeletal disorder among the spine surgeons. 7% undergo spine surgery and 4% cervical spine surgery. And personally, I have operated on a lot of plastic surgeons because they tend to use a lot of loops and they have their neck bent. And in my area, I must have operated around 5 or 6 plastic surgeons, especially because of this loop. So loops also cause neck pain, especially when you use light and loop for a lot of surgeons who still use them. 80% have pain on regular basis if you ask and there's a lot of literature on actually musculoskeletal pain. I was surprised myself. And having disc prolapse myself, I thought only I get pain, but I found that literature supports that a lot of people get back pain and neck pain and shoulder pain and rotator cuff. So almost all surgeons are at risk. So that's important to note. And we have to look after ourselves. There are many types of hazards. In our initial days, HIV, hepatitis, needle prick injuries, they were all very important. Of course, they have now got diminished. Then you have the hazards from the gases, cautery gas and anesthetic gases, and the musculoskeletal injuries, and of course the emotional issues and the stress, which I'll talk a little bit later. Radiation hazards came when Foley introduced the percutaneous sextant system in 2001. After that, there's been a lot of technology leap, as Ajay, Rajkumar said about navigation and then robotic assisted navigation. And all this stuff. So if you are using those, then obviously the radiation is less. And if you want to do a lot of MISS, which is going to be there for sure, then you will need to move on to these new technologies in order to minimize your health risks. And the percentage of vertical screw fixations in the North American Spine Society, we don't have any literature in India as such, is become huge. So almost every center has adopted to minimal invasive spine surgery, especially in insertion of pedicle screws, because it is fast, quick, and the less pain and trauma also for the patients. So this is there to stay, and we need to use precautions or technology in order to preserve ourselves for a longer life of a surgeon. So reduced trauma, faster recovery, low risk of infection, less postoperative pain, shorter hospital stay, better cosmetic outcomes. So there's no doubt about it. So this is there. It is important. It is good. So we all older surgeons have also changed a bit into this. But is MISS harming the spine surgeon himself? And there are 2 types of radiation hazards. One is stochastic and one not stochastic. Basically, if the radiation is much, I think you all use radiation batches, and that tells you the cumulative effect of radiation. But now there is, now from the C-arm also radiation, you can know how much radiation you have got. So you have got all those calculations present also. Most of the radiation orthopedic surgeons are exposed to is not the primary beam radiation. So it is the scattered radiation. And so if you double the distance, you reduce the intensity. And but in spine surgery, I see a lot of people using the C-arm in the lateral view while putting in the screws, because then it is quicker for them. And they are staying in at the side where the X-ray beam is on. So they are exposing themselves to a lot of scattered radiation. So that is important. So the exposure rates were highest when the C-arm was placed in the lateral position and significantly reduced when the primary beam entered the patient opposite the surgeon. So that is important. So it has to be the correct way of how you position the C-arm. And also remember, the radiation in the limb is one, and the radiation in the body is about 10 times more. So the spine surgeons are exposed to more radiation. And there are a lot of papers to show that. Of course, we all use the lead gown. I'm not sure how much use the thyroid shield, and very few use the glass. We have the glasses. I tried it out for a few cases of these vertebroplasty and kyphoplasty, but when you are using your own glass, it becomes very difficult, so you tend not to use it. So, but at least I insist that you should all use the lead gown and the thyroid gland, because if you stand like this without the thyroid gland, the scattered radiation goes directly to your eyes, and a lot of surgeons do get cataract also. I know of 3 surgeons who have got cataract because they, of course, are doing a lot of C-arm guided surgeries. So this is common. We all use this. So when Ajay gave me this talk, I said, let me see in my institute how many cases of MIS and open and what is the radiation, because we use this Zyme C-arm. It tells you exactly what is the radiation to the patient. So we looked into the lumbar spine and dorsal spine fixation. I excluded the kyphoplasty and the augmented screws and the cervical spine. And this is just to say that the gray is the standard, and previously it was REM, and the dose is one gray, equivalent dose is absorbed dose plus tissue weighting factor. And we looked into the screws, the number of screws put in between January and September. 313 screws were open, and MIS were 286 screws. Shorts in, as you can see in the open, were 1629, and shorts in MIS were 5839. Obviously, in my department, the fellows would put in the screws, and we would do the TLIF or the spinal procedures. So there could be a little bias in overexposure, but however, it is statistically highly significant from open to minimally invasive. And in an institution which is changing over from open to minimally invasive, obviously this could be there. But as I showed you the American data, most will get into minimally invasive. So shots per screw in open were about 10, which is obviously less than if we do it. And then MIS were 23, and radiation per screw was 1.41 gray versus 7.2 gray. And now there are a lot of articles which shows that from each patient you can know what is your radiation exposure, and that also you should calculate yourself, and there is a very easy formula from where you can calculate all that. And there are quite good articles on this also. So there is a cancer risk, and I thought of Amit Jhala, who does a lot of OrthoTV, where he says that it is so good and nice, and the cancer risk is definitely less in the patients who get that versus the cancer risk with those who get mini TLIF, because you put percutaneous screws and you then see image and then you put the TLIF cage and etc. So there is also a hereditary disorder risk in these. So guidelines to decrease radiation exposure is distance from the patient, configuration of the C-arm, use of radioperatic equipment, rotating surgeon's eyes away from the patient. So when you are doing the C-arm, try to look at the screen, not at the patient. Avoiding direct exposure to surgeon's hand, and that also is important. Use a sponge holder or artery forceps or something to see the image when you are using the wire or a guide or a dilator or whatever. And of course, surgeons get more experience than you would use less. So if you use the collimeter, most of the new C-arms have the collimeter, you can reduce the exposure, then you will have dramatic decrease in fluoroscopy times and radiation doses. So if you look at this slide, which I have just taken from this article, it shows that in vertebroplasty, in kyphoplasty, and in MIS surgeries, you have a lot of radiation, and the orthopedic surgeons are prone to increased risk of malignancy, and there is a 0.75 time per lifetime fatal risk of cancer on the patients as well as on the surgeons. So it's very important that we keep these in mind when we are doing the MIS TLIF, and which has become a standard procedure where you use a lot of radiation. Now, spine surgeons like me who operate for 30 years or more and have not paid attention to their radiographic exposures like this. I have never used a thyroid shield for well, it's only recently that people have insisted on using thyroid shield, so sometimes I use. I don't know how much of you use still now. So the radiation exposure is significant to that, even the scattered radiation. Should limit their surgeries minimally invasive if they are using the C-arm. So we all have to move on to the technology. So looking at this, this is a questionnaire I sent in January for one of the ASSI talks. I sent it to orthopedic surgeons and neurosurgeons, and we got 210 responses. I have got 2 minutes. Majority were male. So this is, I sent it to all, and a lot of you have got this questionnaire. And I asked them, do you wear protective equipment? And you can see that there was 2% who never wear equipment. That means they don't even wear the lead shield. And there were 27% who sometimes wore. So it's only 70% who always wear protective equipment. So I think if people are still not using, you should be using your lead apron and your thyroid sheet for sure. And none used, lead glasses were very rarely used, lead gloves were not very rarely used. So most people use the lead apron, and some people use the 34% use the thyroid guard. How many cases week? So CM surgeries, a lot of centers are doing more than 25 image guided surgeries, and practice, minimal invasive practice is almost 25-30% or more than 60% is image guided practice. I think this will increase. Most of the newer generation will be probably doing a lot of image guided surgeries. I'm not sure if all the centers, I'm not sure if all the centers would have the OAM or the robotic, everybody can't have Bharat Dave's center with him. So people have to go to smaller towns and do, so you be very careful. You should also receive training. So you must be careful in the sense nobody receives. We now receive training on prevention of radiation hazard or occupational health. So that also is important. And as Rajkumar said, we need to reverse train a lot of things, a lot of technology. So physical hazard is important. This is very important to keep in mind. And there are lots of studies. Actually, I was surprised to know, looking into the physical musculoskeletal problems with surgeons. So as surgeons, we have problems, and from varicose veins to lumbar disc herniation to CMC joint pain, and I can correlate with some of it myself. So that is there. Noise pollution also is there, and with noise, because of the machines, you can get problems. Of course, I would skip the emotional hazard and the stress that surgeons face along with the mentees. And so my message is, be aware of radiation hazards. Use navigation if you're making a career in MISS. Be aware of these gases and other problems, physical and emotional stress, and look after your health, because no one else can do that for you. Thank you so much.